thank you so much to everyone for inviting me. I'm not going to say very much about that because we're running out of time, but I'm very, very happy to be here. I want to say initially that I think that my presentation is perhaps a little deviant in the sense that in a grouping, am I going to get it? Okay. In a context where identity politics plays a very important role, as it does here, and understandably, it's very bizarre to have a woman come up and talk about heterosexual men. Now, one of the reasons for that is that many of the studies, there's a few studies now beginning to be done on heterosexual men, but actually most of them have been done by women. And that's actually very interesting and a question that we ought to ask ourselves. I mean, why is it that women have become interested in researching heterosexual men? So that's my first kind of observation. The second reason I think I'm a bit deviant is because I'm thinking very much globally and not so much about Canada, or rather not so much about the rich world. So I'm trying to think about it in a much broader context. And the third difference is that I'm not talking about a particular study that I've done, although I have done a couple of studies of heterosexual African migrants in London. But I'm trying to do something which is much more conceptual, which is attempting to say if we really try to bring heterosexual men into view much more in relation to the HIV pandemic and the different epidemics in different countries, which is very important, then there are certain kind of challenges that we have to face. And so that's what I'm going to talk about, and I think somewhat differently from some of the others. Can I have it? Can I have it now? Yes? Okay, thank you. So I'm going to talk basically very generally about heterosexual men in the HIV pandemic. And I want to start by talking about what's clearly a paradox of invisibility, that if you look around the world, and particularly if you look outside the rich world, outside North America, Europe, and so on, where, of course, the vast majority of HIV positive people live, then heterosexual men are often blamed for the pandemic, that they're somehow lurking in the shadows as the cause of the pandemic. But very few people have actually tried to make sense of what their role actually is in any kind of detail. And we have no data, for example, on the numbers of heterosexual men infected in different settings. People haven't tried to really look at that in the same way as they have with other groups. We've got very few studies of the experiences of heterosexual men, the qualitative experiences of sex, of health, and of healthcare. And I've said here among men who are either identified by others as heterosexual or who identify themselves as heterosexual. We really have very few studies that really tell us anything about that. And finally, although there have been, and I'll talk about this later, although there are policies that have been designed recently to incorporate men much more into the pandemic, particularly at the level of UNAIDS and so on, most of those policy initiatives are actually not about the men themselves, but it's about how can we get men to behave differently to protect women. So we haven't really been saying, what is it that heterosexual men need, but rather, how can we get them to change so that, we can deal with issues like maternal transmission and so forth. So what do we actually mean by heterosexual men? And that may sound like a silly question, but it obviously isn't. And I think it particularly isn't in relation to some of the things that other people have been saying on the panel. Usually, we would define it very simply as men who have sex with women, and that's how it would appear in statistical accounts and so on. But of course, many men may not be sexually active at all for all sorts of reasons, or they may also have sex with other men. Sometimes that might be because they're bisexual in some kind of traditional sense, or it actually may be because they're male sex workers, which is quite common in many parts of the world, but they're male sex workers who are actually married to women. And of course, this is a very big source of transmission in some parts of the world, particularly in some parts of South Asia, in India, for example. So the kind of binary categories that we normally use in research, which could be either gay and straight or homosexual versus heterosexual or whatever, are obviously deeply problematic. And once you start to look at that, once you start to say, well, what are heterosexual men and how does this work? Then it means that for anyone who's trying to count the numbers of HIV positive heterosexual men and to make any assessment of their needs is very complicated and very difficult. And you're actually working with very slippery concepts, which a lot of the time people haven't basically recognized. They're thinking it's a very simple thing. It isn't simple at all. So what do we know about HIV positive heterosexual men? Well, globally, we know that 60% of HIV positive people are women. So if you're looking at the UN data, for example, what the presentation that you're given is that there are this number of women and then there are this number of gay men. But in fact, all we know is that 60% of HIV positive people are women, and hence the remaining 40% must be male in some form or other. But we actually don't know about their sexual practices or their sexual identities. We actually we don't have that figure that tells us how many heterosexual HIV positive men there are, which is really quite extraordinary, but we don't. And if you look at different parts of the world, then the balance of men in that group will be very different. So in North America, for example, the majority of male HIV positive people are likely to be men who have sex with men. But if you look in the African region, where of course the vast majority of HIV positive men are, probably something like 70%, 75% of them are, they're much more likely to be heterosexual. So we're going to have a very different balance of the two male populations in the different parts of the world, but we don't actually know what that balance looks like, which is really quite remarkable in terms of how we go forward with policy. I don't, in saying that, want to miss out the points that have already been made about gay men in Africa or at least men who have sex with men in Africa, and the fact that we're only beginning to realize that there are a lot more than we thought, as we've heard about Ghana. But nevertheless, it's clearly true that the majority of men who are HIV positive in Africa are in fact men who are heterosexual in inverted commas. Now, this is very important because in most settings that we know of, heterosexual men are less likely than heterosexual women or men who have sex with men to access ARVs. So unlike many resources which go predominantly to men, ARVs actually are, in the heterosexual population, men are actually disadvantaged in relation to ARVs, and they're much more likely to die while they're being treated. So their experiences of HIV, once they're infected, are actually worse than those of heterosexual women, or at least in the rich countries of homosexual men, gay men, whatever we're going to call them. I hesitate to call them gay men because I've worked so much with African men who have sex with men who, if you say, you're gay, they're going, no, and they don't mind saying they have sex with men, but the concept of gay is such a sort of one that socially they don't want you to use. So in all of this, the terminology is just so complicated and so difficult, and you're never going to get it right, but you have to try your best. So anyway, what we then have to do is to explain the patterns of risk in relation to heterosexual men. What is it that puts them at risk, either of being infected in the first place, or of getting worse treatment? Well, obviously there are two things we'd have to look at, the biological and the social. Now, we know that evidence suggests that in most settings, men are biologically less vulnerable than women in the context of vaginal sex. So the men are actually less likely to be infected than the women in a single sexual encounter. I'm not talking about if they have anal sex or whatever, because that complicates it. But in the context of vaginal sex, then it's clear that the men are biologically less vulnerable. But on the other hand, what we also seem to know is that socially constructed gender or what we could call masculinity, seems to be the key factor in increasing male risk, as well as limiting their access to care once they're infected. So the biology does one thing, but that's counteracted, if you like, by the social construction of masculinity. So in a way, we just have to always, as we go through this, keep reminding ourselves that not to conflate heterosexuality and masculinity. Heterosexuality is about who you're having sex with, but you can be more or less masculine as you do that, if you see what I mean. So what I want to turn to now is then to talk about this issue of masculinity. And some of you will be familiar with the term hegemonic masculinity, which was a term which was coined, first of all, by a guy called Bob Connell in 2005. And some of you will know it, which is quite interesting, that Bob Connell, Robert Connell, has now become Raewyn Connell and has actually transitioned. So you'll still find all her work under R. Connell, but now she's transitioned from Robert to Raewyn. So the model of hegemonic masculinity, which he at the time wrote about, was a view that said, even though masculinity varies in different parts of the world, that there are going to be definitely kind of some key core characteristics of how masculinity is defined. And these were the following: that men are expected to be physically strong and not to show weakness. They're assumed to be sexually needy, in fact, irresistible need half the time, with a natural desire for multiple female partners. They're allocated emotional and physical dominance in their intimate relationships with women. They're more likely to smoke and drink than women, or smoke and drink to excess, and also to be injecting drug users, which of course is, the injecting drug use particularly is a very important point, because since the majority of injecting drug users are heterosexual men, then that's one element that we really have to take seriously into account when we're looking at how many heterosexual HIV positive men there were. And of course they're expected to be breadwinners for their families. So what people have done who've tried to make sense of all this in relation to heterosexual men and health, not just HIV prevention, but health generally, they've said, well, what does this mean for men's health behavior in relation to HIV? So what they have argued is that heterosexual men, by definition, if you like, in terms of their socialization, choose to engage in more unsafe sex than heterosexual women, which may be because they want to have more relationships, maybe because they're more keen to make the sex risky by not using condoms. The healthcare system is then avoided by these men as being a female space, or increasingly a gay space. I mean, if you do, there's a number of studies in Africa in particular have shown that heterosexual men are very reluctant to go into that healthcare space, not just because it's about women, but because it's also about gay men. And they don't want to be associated with them either. So what that does is to lead to later testing, poorer diagnosis, less adherence to treatment, and a greater likelihood of early death. So in fact, heterosexual men, because of the way that they behave, it is argued, are if you like, bringing these effects on themselves. So what that means is that hegemonic masculinity, as Connell defined it, can affect both sexual and health-related behavior in negative ways. And that still is the basic lens through which heterosexual men are actually viewed in the context of both prevention and treatment. If you read the literature, then that's kind of given as the explanation for kind of what goes on with HIV, with heterosexual men in the pandemic. But this approach has considerable problems that we have to be aware of. The first is that clearly it does have value in some settings, and one wouldn't want to reject it at all, because obviously there are many ways in which it can be used to kind of understand what's actually going on. But at the same time, models of masculinity do vary over space and time, and heterosexual men will have different approaches, and if you like, different degrees of conformity to the hegemonic model at different times and different spaces. But more than that, if you look at men's own agency, many men are unwilling to perform masculinity in that way. You know, they're saying, well, you know, this is not how I want to be. I don't want to be that kind of a man. And so they may be able to make choices that say, I'm actually going to behave in a different way. And so they'll choose alternatives for how to be men. Some of them live in settings where living up to these expectations is not possible. For example, if you live in a country where you can't work, then because there's no jobs or whatever, then it's very difficult to be the sort of person who is expected to support their family and so on. And individuals will respond differently to these circumstances. You know, some of them will go hyper-masculine as a form of backlash, but others may adopt more egalitarian gender relations. So what's very important when you're thinking about heterosexual men and how to define policy for them, then it's very important to see that masculine attitude, what we call masculine attitudes and behavior, are not innate, but are socially constructed in the context of different communities and relationships. And the other problem I just want to highlight, have I got about 3 minutes or something? Is that about what I've got? You've got about 3. Yeah, right, good. So the model of the model of using hegemonic masculinity, when you use that, when people do studies of heterosexual men using this model, they leave out major areas of HIV-positive men's lives, and that it's critical. And the 3 that I'm picking out for you here is fatherhood, work, and sex. So, for example, almost nothing's been done about the desires of positive men to become parents, which may be very strong. But if they're actually going to do safe sex and be responsible, then they can't have children, almost by definition, not in countries where there aren't high technology options. But very little work has been done on what that actually means to those men. The second area is work. There's been very few studies of the impact of loss of physical strength and earning capacity on men, how it diminishes their sense of manhood and their loss of respect and identity. And finally, we know almost nothing, or very, very little, about the subjective experience of HIV diagnosis on sex life for heterosexual men. People just really haven't investigated it. And of course, I'm particularly interested in this in relation to discordant couples, because if you've got a woman who's HIV negative and a man who's HIV positive, how does that alter the gender balance within their relationship? I mean, what does it actually mean? So just to make sure that I'm not too high up, I've just given you 3 quotes from positive men about these 3 areas. They're all from Africa. African men. So one man from Namibia said, I worry a lot and I can't sleep. I cannot find an income. I worry about support to family members. To think about these things gives me chest pain, and the heart, it feels like someone stabs me in the heart. Then another man from Uganda who we interviewed in London said, you've nothing to eat in the house or a glass of wine for your wife, so you go to bed, but you're fearing to touch her. You can't say, can't you turn this way? And then he laughed, because no, you definitely can't, because he's not able to work and he's HIV positive. Then finally, on fatherhood, another man, another Ugandan migrant we interviewed in London said, well, as a man, you know you want to have a family. If you don't, the elders in that clan or in that extended family begin to say something like, you're useless, you're worthless. So that was another Ugandan migrant who talked about the impact of his HIV positivity. So finally then, just to say something about intersectionality and masculinities. So the important point then is that heterosexual men are not a homogeneous group, clearly. They're incredibly diverse. The diversity takes many different forms which interact with each other to shape these men's vulnerability to HIV, as well as the quality of the care that they receive. And the categories that we probably need to put into the equation for this is socioeconomic status, race/ethnicity, however we're going to define that, and clearly that's, again, very complex. Their patterns of drug use, their age, And of central importance is what I've called geopolitical status. That is to say, do they live in a rich country like Canada, or do they live in a poor country, like Uganda or any other, well, not all, but the majority of African countries. So how they construct and deal with their masculinity in the context of HIV is something which is intersectionally determined, if you like, by all of these different criteria that are coming together in the context of heterosexuality and masculinity. But the interrelationships are very complex and they vary by settings. I'm just checking how, okay, so I'll just finish this. For example, I just want to make one point which I think is important here. In the US, for example, the high and increasing rates of HIV morbidity and mortality in what's seen as a heterosexual subgroup of African Americans and African migrants is attributed to a combination of oppression, stigma, racism, and poverty. So in the US and in Canada too, these men are seen as a deprived minority in a rich country, if you like. So therefore, race, ethnicity, whatever we're going to say, becomes something which is clearly associated together and with HIV. In the African region, on the other hand, black men are clearly in the majority. They are. African men are black. And rather than being a subgroup, they are, in fact, the population. And indeed, in Africa, wealthier men are often at a greater risk than poor men, although, of course, they're likely to get better care, but they're often at greater risk of actually contracting HIV because they actually end up in a situation where they can actually have more girlfriends and women and so forth. Yes, so finally, these are the implications, I think, for research and policy. Yeah, you've got the implications for research and policy up there, and they're pretty plain anyway, that we have to, it's really about diversity, and that we have to explore the models of masculinity that shape the identities of men in very specific settings, that it's not that there's heterosexual men and that's it. But that we also need to be aware of the many structural factors that are placing constraints on the options of men who want to be identified as heterosexual. And I think what it raises for me anyway, in relation to what we've been talking about here, is it feasible to target heterosexual men as a group, which is what, was kind of implied in the title of the thing. Or should the focus be on specific subgroups of heterosexual men or men who have sex with women, like IDUs? And it seems like maybe in North America and in Canada, if you're talking about black heterosexual men, then maybe you can put them as a specific group. But if you're in Africa, you clearly can't put them as a specific group because they are half the population. So how do you take that into account in terms of how you plan policies and targeting? And then finally, I think we have to talk about how we reconcile the needs of heterosexual men with those of heterosexual women in the context of both prevention and treatment, because obviously when you're talking about heterosexuality, you're talking always about relationships, about women and about men, and it's a relationship, and how do some get more and some get less and so forth, which is rather different from some of the other groups where it isn't that kind of relationship. You can talk about a group of men in prison that we've talked about before, for example, and you can think of them as individuals or an individual in a way that it doesn't really work with this. And so I think we have to talk about how we can reconcile the needs of heterosexual men with those of heterosexual women in the context of both prevention and treatment across a range of settings. So I stop there. Okay.